Advanced Palliative Care. Welcome to today's webinar, Understanding the 2014 Comparative Performance Reports from the National Palliative Care Registry. I want to remind everyone that the recording of this webinar will be available on the registry website. Before we introduce our presenters, I want to let you know how you can participate in today's event. In the upper right corner, you should see a control panel where you can change your preferences and interact with the speakers. By clicking the orange arrow, you can open and close your control panel. After our presentation, we will be hosting a Q&A session. Throughout the presentation, we encourage you to type in questions and comments using your questions pane. Simply type in your question and click send, and we will do our best to answer all of your questions during the Q&A. If you would like to speak to the presenters during the Q&A using your phone, please indicate this by virtually raising your hand. This option is located on the left tab of the control panel, and as time allows, those with raised hands will be addressed and unmuted individually during the Q&A. Now, it is my pleasure to introduce today's presenters. Dr. Diane Meyer is Director of the Center to Advance Palliative Care. Under her leadership, the number of palliative care programs in U.S. hospitals has more than tripled in the last 10 years. She is also Vice Chair for the Public Policy and Professor of Geriatrics and Palliative Medicine and Geisman Professor of Medical Ethics at the Icahn School of Medicine at Mount Sinai in New York City. Samara Devonsky joined CAPC in November of 2014 as VP for Research and Analytics. With a strong background in public health research and program evaluation, she has extensive experience in applied research, evaluation design, survey development, and data analysis. Samara received a doctorate in sociology from New York University. Maggie Rogers joined the CAPC team as a research associate in early February. Her background in quantitative research and interest in chronic disease and cancer led to a natural progression in the field of palliative care. Maggie loves the power of data and enjoys using data analysis and visualization to help solve real-world problems. Maggie holds a Master's of Public Health and Epidemiology from Rutgers University and a BA in Psychology and Gerontology from Ramapo College in New Jersey. Please join me in welcoming our presenters. Dr. Meyer, take it away.
Thank you very much, Brittany, and welcome everybody. I'm thrilled that so many people are joining us for this conversation and presentation. As many of you may already know, we began the National Palliative Care Registry back in 2008 because there simply were no national data on the prevalence of palliative care capability in hospitals in the United States. And we thought this was important to develop for a couple of reasons. One is facing outwards towards policymakers, payers, health system leaders. One of the best ways to make the case that palliative care is important and they should pay attention and invest in improving access and quality is for people to see how many other people are doing it. And to recognize that this is a social innovation that is not going away, that in fact it's growing rapidly. So that was one reason, was to sort of help get the message across and make the case in organized medicine and all its various sectors. The second, though, and probably more important reason, was to help individual palliative care program leaders and health system administrators understand how they were doing, both compared to themselves year over year in the past, and then also compared to their peers. So it's really important, for example, if you're running a palliative care service in a 300-bed community hospital, to know that most of your peer programs in 300-bed community hospitals have an average of, say, I'm making this up, 3.5 FTE and are reaching 5% of annual total admissions. And if you have those data and your program is far less well-staffed and making far less impact in terms of penetration of your service to people in need, you have data that you can take back to your administration, your team, the people who hold the purse strings in terms of resources that are needed to support and grow your program, and say, here's how we compare to peers, other 300-bed community hospitals across the country. And the fact that we are significantly understaffed in comparison to our peers is reflected in our difficulty reaching patients in need. And we've learned over the years that program leaders have been able to use these data very effectively, both to kind of demonstrate to their own institution the national impact and reach of palliative care, but also in a much more specific way to show how their own program is doing compared to peers. And as a result, we are investing increasing resources into expanding participation in the registry and expanding the content of the registry to go beyond hospital settings to include settings in the community. What's happened recently is that participation rates are growing significantly, and as it happens now, the National Palliative Care Registry is the only national data source for operational variables on palliative care program operations. And we want to encourage everyone, those of you who have been contributing data, to continue doing so, and those of you who have not, to begin doing so. One very important point I want to make is that there's been some confusion since CAPC became a membership organization in January of 2015. People thought the registry was only for members, and that is not the case. The registry is a free service to everyone working in the field, whether or not you are a member of the Center to Advance Palliative Care. The goal is to maximize participation so that the data are valid and helpful to everybody. So I'm going to turn the presentation over now to my colleague, Tamara.
Thank you, Diane. I appreciate that introduction. Going to activate this. So we want to give you a quick overview, and Diane did a good job of this. So just to reiterate that the registry is the nation's only repository for data on hospital-based palliative care team characteristics and best practices. And as Diane already mentioned, we are hoping to expand that to other sites of care. Reiterating again what Diana just said, that it is free and open to all hospital-based palliative care programs. I want to give you a quick overview of just the participation rates in the 2014 registry. Then we're going to go over some key metrics, and we have some case studies, and then we'll talk about what's next for the registry. So in 2014, we had 398 programs participating in the registry, and they represented 482 hospitals in 47 states. We want to do a quick audience poll. So did your program participate in the 2014 registry? Just take a few minutes and answer this question and let us know whether you participated, whether you got a report, and I guess the answers are going to come up now. Have you participated in the past? Are you thinking about participating in the future? So as Diane mentioned, participation rates are going up, and we're really excited to see the numbers steadily increasing year over year. And Brittany, did we get responses?
Yep.
Yes, that's great to see that among people who are on the call right now, 64% have participated in 2014 and did get your report. And we're very happy that the 25% of you who are interested in participating in the future are on the call to hear more about it. So Diane also mentioned that for comparative purposes, we do look at who's participating by hospital size, and we use total hospital beds to categorize hospitals. So you can see that the majority of registry participants are in hospitals with 300 or more beds, but we also have strong representation in smaller hospitals as well. The three key metrics that we're going to look at today are palliative care service penetration, staffing levels, and length of stay. We'll go through each one of those and show you some of the results from the registry and talk about how you could use these data to help you with your program. I think I might have, no, the slide is here, sorry. Okay, so palliative care service penetration, the first metric, it's really an estimate of how well programs are reaching patients in need of palliative care. So it's one of the central and most important metrics that we have. It's basically just initial palliative care consults as a percentage of annual hospital admissions. For 2014, the overall palliative care penetration across all programs was 4.4%. You can see that the range is pretty wide, but over time you can also see that it's steadily increased. So from 2012, went from just 3.6% steadily to 4.0 up to 4.4. So we had talked about looking at hospital size as an important comparative category. So we don't want to compare larger hospitals with smaller hospitals. This slide demonstrates that there is variability by hospital size, with smaller hospitals having higher penetration rates. So hospitals with fewer than 150 beds have palliative care penetration of 5.8, while larger hospitals have penetration of 3.7. This is why it's important to compare to peer organizations. The interdisciplinary team is the next thing we're going to look at. The disciplines that can be part of an interdisciplinary team are physicians, advanced practice registered nurses or physician assistants, chaplains or spiritual care professional, social workers or psychologists, and a registered nurse. And we recognize that there's different patterns of staffing for different teams. And I'm just trying to get to the next slide. I think we skipped a slide. Oh, so we have another quick poll right now. And so we're curious to know, because we hear back from a lot of people that staffing patterns vary a great deal. So who leads your palliative care team? Is it a physician? Is it an APRN, an RN, a social worker, or someone else? And I know that the staffing patterns also vary by geography and by hospital size and hospital location. So we're really interested to hear how your programs are staffed. So I think we give it a few seconds to get everybody's votes up. And this is great to see that everybody who's on the call now, so 58% are staffed by a physician, but 21% are staffed by an advanced practice nurse. It's interesting to see that there are different kinds of patterns of staffing. This is something that we're going to explore a lot more going forward with the available registry data. So when we look at staffing and we kind of break staffing out into quartiles, we can see that there's a direct correlation between staffing levels and penetration rates. Programs with higher staffing levels have higher penetration rates. And we know that insufficient staffing is a barrier to reaching patients in need of palliative care. So this is an important kind of metric that demonstrates this association. So a couple of other metrics around physicians. You guys have just told us about your staffing. 70% of programs have a physician, at least any FTE of a physician's time on their palliative care team, while 44% of all of the programs in our registry have at least one full-time physician on their team. For advanced practice nurses, the correlating numbers are 72% have any FTE of an advanced practice nurse, while 65% have at least one full-time advanced practice nurse on their team. The final metric we're going to look at is length of stay. And obviously, length of stay is important as a quality measure and a potential cost outcomes for this measure. So we look at two categories of length of stay: time from admissions to consult, and then time from consult to discharge. We can see that there's a direct correlation between palliative care service penetration and length of stay. So the greater reach that you have in your hospital to patients in need of palliative care, the lower your time to consult is going to be. So this is an important thing. There was a recent study in the Journal of Clinical Oncology that found cost savings linked to early palliative care consultations. Specifically, consults within 2 days of admission reduced costs by 24%, and that translated to almost $2,300. So why use the registry? We talked a little bit about this already. What's important is that you can contribute to the national profile of palliative care programs. For your own program, you do get comparative data to help you evaluate your program against similar programs. And you can track your progress over time. And then your data is included in national reporting, and you're part of a growing field of research. It also helps you to manage and grow your own program for best impact on patient care. And we know from what we hear back from programs is that they use the registry data and the national comparison reports to advocate for their programs. They can tie the operational metrics to quality improvement. It helps them to diversify their palliative care teams, and it helps them to track their operational metrics over time. Now we have a few case studies, and Maggie's going to talk to you about a couple of those.
So the first case study we're going to talk about is Rutland Regional Medical Center, which is in Vermont. So Rutland Regional has been participating in the registry since 2008. And while they initially used the registry reports as a self-assessment tool for internal quality improvement, they've now grown to use the reports and data for quality reporting to the CEO, the board of directors, and even at quarterly cancer committee meetings. For example, data from the registry report was presented to the CEO as part of a position review document to secure additional staff from 2.0 to 2.5 FTE nurses. Most recently, Rutland has used the registry reports extensively for community fundraising for their palliative care program. The registry comparative report really helps them make a strong case to potential funders to donate to their palliative care program. They now have plans to post the registry reports on their hospital intranet for staff to see and on the hospital internet for all visitors visiting their page to see. The second case study we're going to talk about is Trinity Health System. Trinity has over 10 hospitals submitting to the registry, many of which have been participating every year since 2008 when the registry began. Trinity uses system-level aggregate reporting to compare to national standards. They continue to present their registry data at routine standard meetings to corporate management, corporate operational, palliative care program site leaders, and palliative care metric meetings. Trinity also presents their aggregate registry data alongside their electronic medical record, or EMR, clinical quality improvement outcomes. They also use the registry data to set benchmarks and targets for their hospitals and for their entire health system. Now I'm going to show you two graphs to illustrate some of Trinity's aggregate comparisons. The first graph shows Trinity Health System's 10 hospitals in the registry and how well they are able to reach patients in need, or what we refer to as penetration. The orange line represents the national average penetration across all hospitals, and the green line represents the average penetration for the top performing quartiles of hospitals. As you can see, Hospital 6 is reaching an estimated 9.9% of all hospital admissions, which is higher than both the national average, the orange line, and the average for the top quartile, the green line. While Hospital 1 is only reaching about 1.8 of their hospital admissions, which means that Hospital 1 is most likely not reaching all the patients that would benefit from palliative care. This slide shows the average funded full-time equivalent, or FTE, per 10,000 hospital admissions for Trinity hospitals and the rest of registry users. As you can see by comparing the blue and green bars, Trinity is consistently understaffed for all positions in the interdisciplinary team. A graph like this could be used to make the case for additional staffing. The next case study is Fairview Health System. The University of Minnesota Medical Center and Fairview Southdale Hospital both submit annual data to the registry. The first is a large academic hospital, and the second is a small community hospital. So Fairview Health System's programs represent a range of the types of programs that submit data to the registry. The comparisons they receive from the registry motivates their internal team discussions and helps them to set targets for team productivity. The data also helps to respond to leadership questions. For example, they may be asked a question such as, how many patients should you be seeing? And the registry data helps provide important context for this conversation. The report strengthens proposals for program growth and moreover supports the value case to leadership. The comparative data illustrates what would be gained with increased staffing,
such as reaching more patients in need, which was a graph that we showed earlier on slide 13. The last case study we're going to talk about is Baylor Scott and White Health. So Baylor Scott and White Health is another huge participant in the registry. They currently have about 10 hospitals submitting data to the registry every single year. The registry is the only place to go for benchmarking targets. Other service lines routinely rely on national comparative data, and the registry is the resource for comparative data on palliative care. They've used the registry data to set attainable system-level goals, including providing palliative care to a total of 5 to 10% of their total hospital admissions, and reducing their mean length of stay from hospital admission to palliative care consult to less than 4 days. Having registry data available to them helped them to secure Joint Commission Advanced Certification in Palliative Care and the American Hospital Association Circle of Life Award. Across the board, we have continuously heard that senior leaders need to see data, and the registry reports help make the case for palliative care programs. We have Martha Filastri on the line from Baylor Scott and White Health. Martha, is there anything that you would like to add?
Hi, this is Martha Filastri, and I just stress how valuable it's been to have a place where we can pull this data from. And every other service line has metrics that they report to senior leaders and have benchmarks across the nation, and we really don't have that, and this is allowing us this opportunity to finally get that. And it's been really important to be able to tell senior leaders that this is a national repository that is nationwide, and getting information from all these other hospitals, and we're able to share this and compare and help move this forward. And we share this monthly data to our team leaders on a monthly basis, and then we send it to our senior leaders on a quarterly basis, and it has helped just evaluate ourselves as to where we are and where we're moving to, and how to make things move forward quicker. Our hospitals, we have 10 hospitals in the registry, and they range from staffed beds of 67 to 805. Each of them have their own president, their own CNOs that make their own decisions, and so being able to compare each other and having this registry to allow us to compare nationally has really been beneficial in helping us make our case.
Great, thank you so much, Martha.
So now we want to talk a little bit about what's coming up next with the registry. We know that people have been entering a great deal of data into the registry, and I think what we hear from the feedback from people is that it's incredibly valuable, and the reports are incredibly valuable. There's data that have not been in the reports, and that's the data that we want to get back out to all of you. So by September 2015, we hope to have a complete summary of all the registry data and breaking that down by hospital size. We want that to make it available to everybody as an easy point of reference for key operational metrics. And we do think, as Martha just mentioned, it's a first step towards developing operational quality benchmarks. The second thing that we're working on is a registry toolkit, and we really want it to be a single point of entry so that people have clearly identified definitions for the key metrics and ways to calculate them. Once we post this presentation online, at the end of the presentation there's several slides that outline some of these definitions and calculations. Another thing that we want to make available to everyone is summary of key points from published research that will help you make the case for your palliative care team. And we are also going to develop a series of summary reports on special topics for registry data that we'll start posting in the fall of 2015. The bigger thing that Diane mentioned in her introduction is the registry redesign. We are going to revamp the registry. We're going to make it more accessible and easier for users. There'll be modules so you can enter data on specific topics of interest throughout the year, and you'll get instant tables and graphs and comparisons. As Diane also mentioned, we are expanding this to all care settings consistent with CAPC's mission for palliative care everywhere. And the newly redesigned registry will be available in early 2016, and open for 2015 data collection. So that's the end of the presentation. We are welcoming any questions and comments.
Great. So thank you, Dr. Meyer, Tamara, and Maggie. So we will begin our Q&A now. So to ask questions, simply type in your question in the questions pane and click send, and we will do our best to answer all of them. But if you would like to speak to the presenters using your phone, please indicate this by virtually raising your hand. This option is located on the left tab of the control panel. And as time allows, those with raised hands will be called on and unmuted individually. So our first question comes from Jessica, and she wants to know, for the penetration rates, do you use total hospital admissions, or are you excluding OB, psych, and etc.? What are these metrics based on? Want to make sure that we are consistent with our denominator.
Yeah, that's a great question, and it comes up a lot. And Maggie has done a lot of investigation into this, and she can answer this question.
So we try to keep our definition consistent with how the American Hospital Association measures admissions. And so their definition of total hospital admissions are all hospital admissions excluding newborns. So if it's included in the total admissions, then it's included. If the psych admissions are something that is completely separate, then they should not be included.
Okay.
I think that should answer the question.
Great, thank you. Our next question is from Christine, and she says, can you please review the penetration numbers in regards to unique patient consult versus a consult that has been seen by a team in the past?
I'm not sure I understand the question. So, so you're saying a new initial consult versus a patient that's coming back? Is that the question?
Yes, I believe that's the question.
Yeah, that's something that we can look at. We haven't looked at the data that way, but that's something definitely that we will consider, and we can add that into our data analysis plan.
So it's, can you hear me? This is Diane. The denominator is admissions, not patients. So if the same patient has been admitted 5 times, they will have 5 admissions.
Right.
And so right now what we're looking at is admissions, not unique individuals.
Esther wants to know, what would be the ideal penetration rate? Can you remind the group what's considered an ideal penetration?
I'll leave that for Diane.
Oh, thank you, Tamara. So, you know, it really depends. On average, in a U.S. hospital, roughly 2% of annual admissions die every year. And that may be higher in a quaternary or tertiary care setting that only takes care of really complex sick patients. But that's the average, and actually most hospitals cluster around that 2% number. So since palliative care is appropriate for people who have serious illness but may not be dying in any predictable way, we basically estimated that roughly 5 times that number, or 10%, of annual admissions might be an appropriate reach goal for penetration on average. But that depends on a lot of individual variables. So for example, at Mount Sinai Hospital, which is a teaching hospital where a tremendous amount of our faculty and our team, nurse practitioners, social workers, chaplains, effort is spent with learners, medical students, nursing students, nurse practitioner students, fellows from multiple specialties, we don't make the kind of penetration that a team would that is focused solely on clinical service delivery. So, you know, it kind of depends on what are your other goals and objectives for your program. They may be much broader than just seeing patients in the hospital. And so the statistic has to be weighed in the context of all the things, all the work that your team is attempting to do in addition to seeing hospitalized patients. So I think it's very important to contextualize the number. There are some hospitals, as Tamara pointed out, that are up around 16 to 18% of annual admissions. And that's a very, very high and unusual penetration. And it may be that the goal of the palliative care team in those hospitals is just to see patients, no other obligations or services. And that there's a much higher willingness to use triggers or checklist tools to identify patients who might benefit from palliative care rather than waiting for an attending physician to call in the consult. So I think all those things influence what your goal penetration ought to be. At a minimum, I would say, though, in terms of just looking at patient need for palliative care in the hospital, it's probably at least 10% of annual admissions.
Thank you, Dr. Myers. Our next question, could you please clarify hospital admission numbers in regards to inpatient versus observation patients for the registry? Which patient should be included?
Yeah, we just started having this conversation internally, and as we redesigned the registry, we were going to add questions about observation beds. Diane, again, I will defer to you.
Yeah, right now, observation admissions don't count as hospital admissions in the AHA and other major national databases. So we're going to have to figure out a way to identify that denominator separately from hospital admissions, because that number is growing very rapidly across the country.
Great, thank you. Danielle says, do staffing patterns differ between academic and community hospitals? And are physician-led services more common at academic hospitals?
Do you want me to take that tomorrow,
Yeah.
Maggie?
Yeah, go ahead.
Yeah, they do differ, and yes, physicians are more likely to be in leadership roles at academic teaching hospitals because they're medical school linked, so it's a medical school. But increasingly, and the leadership issue in some ways is less important to me than the representation of different disciplines on the team. And I think you saw from the data Tamara showed earlier that a majority of the teams reporting to the registry have both physicians and advanced practice nurses on their teams, and I'm seeing that increasingly as the standard of practice because these are such sick, complicated patients, usually with multiple chronic conditions in extremis because they're in the hospital in the first place. And given that the vulnerability and the complexity medically, not to mention socially and psychologically and spiritually, that increasingly programs are realizing they have to have a strong presence of either advanced practice nursing or physicians, or preferably both. Again, given the, it's like an intensive care unit population in many hospitals. Very, very sick, complicated patients that need pretty sophisticated clinical expertise.
Great, thank you. Jennifer wants to know, so we are a new program and we have not yet submitted data. How do we access the registry data?
The registry, as we said, is open to all programs, and we welcome new programs. Right now, we're transitioning to a new platform, and we have closed data entry for 2014. But we can work with specific programs if they're interested in entering data for 2014. You can get in touch with us by going to the registry site, registry.capc.org, and emailing us through the registry help desk, and we can talk to you more about that.
Thank you.
I think, this is Diane, let me just add to that, that in the past there was a period, a fixed period of time for data submission, usually the first quarter of the new year, to submit data about the prior calendar year. As Tamara indicated, we're going to be moving towards a system when you can submit data at any time and get both feedback on your own program and peer comparisons at any time. There will still be a deadline at some point, so we don't want people submitting 2015 data in 2018 or 2017. We want it submitted in 2016 for the year before. But we're going to move away from a fixed period of data submission to an open data submission process. Is that accurate, Tamara?
Yeah, that's right.
Great. Kanisha says, can we edit data entered for 2014, and will the report update once we submitted the new data?
Right now, it's the same answer that Diane just gave. Right now, there's limitations on the system, and it's hard to update it. We can update it for you, but we have to do it from our end. So again, you can get in touch with us. But with the new system going forward, you will be able to update your current data, your historic data, if you find errors in it. and that process will be a lot more user-friendly on your end. But if you wanted to, if you find an error in your current report, please reach out to us, and we can help you with that.
And I should just say that people do that all the time. So.
Yeah.
So Andrea wants to know, so do you know if there's an equivalent registry for Canadian institutions?
What kind of institutions?
Canadian?
Comedian as in comedy?
No.
Canada.
Canada.
Oh, Canadian institutions. I don't know. I don't know. That's a really good question.
I don't think there is, just because we have gotten interest from Canadian hospitals to participate in our registry. But I'm not sure.
All right, so we can do some digging for you, Andrea, and we'll get back to you. Linda wants to know what data will be collected for the community and outpatient programs. I would like to be ready to enter our data when the registry expands in 2016.
That's a great question, and thank you for that. We are working on that right now, and I think the rollout will be a little bit slow, so we're going to go through kind of priority areas and come up with specific questions that are most useful to people right now on the ground. But the first round of questions are likely going to be kind of descriptors of your program and how you're connected to networks or other systems and the types of services you provide. And we're going to try to develop a core set of process and outcome measures. But we're still in the developing process for that. But we hope to roll it out, kind of do a soft rollout of that and make sure we get feedback from people so that we're collecting the data that people most need to advance their own programs. I mean, Diane, do you want to add to that?
Yeah, I just want to say that one of the key steps that we are about to take is to ask people working in those settings what would be the most valuable metrics to you. So the hospital, the evolution of the hospital registry was a lot of work with end users who were working on hospital palliative care teams who told us what they needed, and the registry reflects basically what the customer says would be most helpful to them in their job. We want to try to do the same thing in this very broad and complex range of settings outside the hospital, which includes nursing homes, home-based programs, which are both certified home health agencies, and house calls programs. We want to see what people might need in a dialysis unit or a cancer center or an office practice or a clinic. So we're talking about a whole bunch of different clinical practice settings that probably have different needs. And we want to begin, with some basic things. Are you delivering care in any of these settings? Yes, no. If the answer is yes, how many people did you serve in the calendar year? What is your staff makeup and FTE ratio? What are the sources of referrals to your program? Are they coming from the ED? Are they coming from the hospital? Are you getting referrals from hospices for patients who are not eligible for hospice? Sort of understanding how the patient flow occurs, understanding something about the length of service. How long do you follow patients? It's very interesting how diverse some of the community-based palliative care programs are. Some are clearly just pre-hospice programs, taking care of people who, the great majority of whom transition rather rapidly to hospice, and others are following people for years with chronic diseases. So those are off, from our initial discussion, the sorts of, and we will be very interested in how your program is financially supported. Are you supported philanthropically? Are you supported on a per member per month contract with a payer? Are you supported by your parent health system or hospital? Again, to try to understand how everyone across the country is cobbling the resources together that are necessary to respond to the needs of patients, both so that we can work on policy to standardize access to that kind of care, but also to help everyone see what everyone else is doing so you can get ideas and replicate the things that are working. And I think if people have, we will send out surveys asking people, among these various metrics and variables, how would you prioritize them? How difficult or easy is it to get these numbers? how important is it to get these numbers so that what we're doing actually responds to what you need in your own setting.
Connie wants to know, would a freestanding palliative care program be able to access the registry? We are a freestanding hospice and palliative agency not affiliated with a hospital.
Yes, definitely with the new registry redesign. Diane, do you want to speak to that?
Well, again, if you are a freestanding palliative care program delivering care in a hospital or a series of hospitals, if you can get the data from the hospital you're working in, or if you're keeping it yourself, you can certainly submit data. As was noted earlier, there are many palliative care programs that are serving multiple hospitals, and they're submitting data for multiple hospitals. So by the same token, there are a number of hospice-led palliative care programs submitting data to the registry for the hospitals that they serve. But again, going forward, if either you have trouble extracting the data from your hospital partners or you haven't been keeping it, it will be easier for a broad range of programs, services, settings to submit data in 2016. But many hospice-based palliative care teams working in hospitals are submitting their hospital's data. I hope that answers your question.
Thank you. Adil wants to know, so she says, I'm curious to know how other hospitals collect and track their data. For instance, our team has been keeping an Excel sheet and inputting data manually.
I can speak to this just from anecdotal things we've heard from people. A lot of people do use the registry as a kind of a foundation to develop a data collection tool in-house that is like an Excel sheet. Other people work with their IT folks to try to get some of the registry pieces out from their electronic health records. So there's a lot of different ways that people are collecting the data out there, but we're listening to kind of people's interests and working with them to figure out ways to make it easier to collect the data, and part of the registry redesign is going to address some of that. Diane, do you have others?
Yeah, I mean, one of the things that I think would probably be helpful for us to do in the future is to identify user groups, registry user groups, using the major electronic health records, Epic, Cerner, Allscripts. Cerner, for example, is working with us now to try to make sure that the electronic health record actually can populate the registry. We would like to see the same kind of partnership with Epic and Allscripts. And I think having user groups, registry user groups that are linked to this, you know, the dominant electronic health records in the United States, the end user is their market, so they want to be responsive to their market. They're going to be more responsive to you as a hospital that contracts with Allscripts than they're going to be to CAPC. So I think we need to kind of help make a consistent and standardized case to the EHR vendors to get them to help us populate the registry, to reduce the data extraction and manual labor that's necessary to do so.
And our next question comes from Jeanette, and she says that my healthcare system has most of its hospitals in California, and the biggest criticism is the lack of tracking clinical metrics and outcome measures. Are you planning on collaborating with the UCSF, Dr. Pantalet's group, who have the PQRS database and have those metrics included in their registry or database?
Diane, do you want to speak to this?
Well, so here's the problem. As those of you who are gathering and submitting data to the Palliative Care Quality Network, which is Steve Pantalet's initiative in California, it's not easy to get that clinical data to submit. The labor, the opportunity cost is high. And we made a decision not to trade off participation for perfection. So while we would like to include clinical data like pain levels, for example, the multiplier effect on the work of the team submitting the data was so significant that we decided not to do that at this point. We've been trying to figure out how to collaborate with the Palliative Care Quality Network so that people can essentially do modular reporting. If you want to do symptom reporting, you can use the PCQN modules. If you don't want to do symptom reporting, you can use the straight registry modules on structure, process, measures, the kind of outcomes that we described earlier. This is going to become very important because CMS is going to start paying doctors and hospitals based on, if not the achievement of specific outcome measures, based on participation in certified quality, data quality registries that we, the field, the coalition, the Hospice and Palliative Care Coalition, is now looking into whether we should begin building a qualified clinical data registry so that palliative care teams can qualify for value-based payments from Medicare and other payers. And the measures in the qualified data registries do not have to be clinical outcomes. They can also be structure and process outcomes. So we've got to figure out what's the minimum that's required in order to qualify for bonus payments, essentially, and then make such a registry available to all palliative care clinicians and programs in the country, because it is going to be linked to your payment. So that's a work in progress.
Great, thank you. Our next question is from Ray, and he wants to know, in looking at staffing levels, do you make distinctions regarding discipline, or is it based on FTE, regardless of discipline?
Right now, the metric is across all disciplines, and it's total FTE, so we don't distinguish. That's something that we're interested in exploring a little more, and this was kind of a first cut at that, is to understand how teams are structured. So we do plan to look at the data in more detail on that level, but right now the metric is total FTE. Thank you.
Marnie wants to know, so she says that their behavioral health makes up 1/3 of their admissions, and that includes like a 30-bed adolescent and child psychology. Would that be factored in the total hospital admission?
So this is an issue that's come up a few times, and in the AHA data, in most cases, those numbers are included. And while we kind of rely on the AHA data as the baseline, programs can adjust those numbers if your admissions, if it's a totally separate and distinct unit, and if the admissions are going through a separate avenue, then they may not be included in the admissions. Maggie, did you want to speak something to this? She's had more direct contact with people on this issue.
I think one of the big issues is that you need to make sure that your numerator and your denominator are representing the same population. So if your palliative care team has the opportunity to have consults throughout all of the hospital admissions, then your denominator needs to be all the hospital admissions. And that's something that we've seen issues with the observation beds from the question earlier, where programs that were providing consults to observation beds, but observation beds were not included in total admissions because they're not true hospital admissions. And in that case, they took the observation beds out of their total consults. But in terms of hospital admissions, we try to keep it standard across how everybody is reporting it. And we do understand that there are big variations for psych and rehab and stuff like that within each hospital. And you may not actually be seeing those populations. So it's something that we're going to continue to look at to see if it is if it really does affect the data kind of disproportionately for those programs. But it's definitely something we're going to continue to look at.
And I think it's a good point because it does vary so much from hospital to hospital that it may be something that we can add in to our data collection so that we understand a little bit better about what the denominators are.
Thank you. Karen says, shouldn't the penetration goal be determined based on optimizing the outcome of the service, and will the registry begin collecting outcome-oriented results?
Diane, do you want to speak to that?
So the question is, what's the measure? I mean, is it satisfaction? Is it likelihood of the patient and family recommending that hospital or that team to others? Is it pain and symptom levels? Is it likelihood of timely referral to hospice or penetration to hospice? Is it impact on 30-day readmissions? So it's not a simple matter to assess the quality impact of a palliative care program. For example, in a big multi-center NCI-funded research study we did on patients receiving palliative care, cancer inpatients receiving palliative care, the pain levels were so low at baseline. Surprisingly, I thought they would be high. They were not. They were so low at baseline that we were unable to show any impact across 8 hospitals of palliative care teams on reducing pain in cancer patients because the symptom burden just wasn't that high. And as it turned out in retrospect, most of those consults turned out to be for goals of care and discussions about what to do next in the context of an advanced cancer. So it's not a simple matter to measure the clinical outcomes of palliative care. We know from tons and tons of research that palliative care does improve outcomes. Do we need to keep reproving that point over and over and over, or do we instead need to make sure that palliative care, which is known to improve outcomes, is actually reaching the patients who could benefit from it? And at this point, we are focusing on the latter, the access to palliative care within hospitals and the capacity of teams because of disciplines, because of obligations to other things like teaching, to reach patients in need. So we'd be really interested to hear if people want to be reporting symptom levels, whether or not somebody was prescribed a laxative. Right now, you can do that by participating in the Palliative Care Quality Network, which unfortunately at the moment is not free and costs about, I don't know, $5,000 a year to participate. But that is a platform that's available for you to look at clinical outcomes data as opposed to how many people are you seeing and how quickly, types of data that we are doing.
Great. We have a lot of great questions, so thank you all for submitting. Our next question is, does the registry accommodate either calendar or fiscal year data?
The registry is based on whatever your reporting year is. So if you generally report by calendar year, then you should do that. If you have a fiscal year that doesn't align with the calendar year, you can also report it that way. So whatever your year is what you can enter.
And most people report using a calendar year.
Okay, thank you. My next question is from Yusimi, and she says, do you have data on penetration rate of an APN-based palliative care team versus an RN-led palliative care team?
That's on our list of things that we're going to look at. We do have the data to look at that now, so we're excited, and that's part of our analytic plan going forward to use the registry data to get some of these metrics out to everyone. So we're going to add that to our list. Thank you for that question.
Awesome, wonderful. Emmy wants to know, are there any future plans to create a registry for pediatric programs to compare?
Diane?
Yeah, I mean, if we get enough pediatric programs submitting data, then we'll have a comparison group. There's no limitation to pediatric programs participating now. The problem is you can compare to yourself submitting data year over year, but if we don't have a sufficient number of programs participating, it's very hard to have valid peer comparisons. So we would love to have all the pediatric palliative care programs in the country submitting their data.
And that's another analysis that we're going to do, is look at how many pediatric programs we have, and if we feel like there's enough there to do some reporting on those programs that have entered data into the registry.
Tamara, do you remember how many we have?
I want to say 20 something, a low 20 number.
Yeah.
Thank you. Kelly says, is there any thought about organizing data so that systems with multiple programs can compare to other systems?
Yes, that's part of the redesign, that we're going to be able to get system-level reports. So if you are a system, you can run a report for your system together. This is an added layer that you're asking about, which is, can you compare to other systems? So that's something that we will think about. We just need to kind of think through what the implications of that would be. But that's a very good point, just because there's so many more systems and systems are growing so much.
Yeah, this is Diane. One of the problems are that systems are defensive and proprietary. So for one health system would not want to be shown up in a public way as doing not as well as a competitor system. So that gets tricky.
And I think we have time for maybe one more question. So Patricia says, our hospital submitted data for 2014 and we haven't received our report. When will that be available?
The report should be available online, so if you don't have it, please contact us, and we'll make sure that you get that. So what was the name of the program?
I don't have the name of the program, but the name's Patricia, but we can reach out to her.
Okay, so Patricia, if you can please go to the registry help desk and send us an email, and we'll get right back to you.
Or you can just log on. You can log on to your account on the registry.capc.org. And if you go to MyPal and you go to My Reports and you did submit your 2014 data, your 2014 report should be there. So you do have to log on to get it. It's not something that is emailed to you.
Okay, great. So we are at 2:30, so those are all the questions that we have time for today. Thanks to everyone for joining us, and a special thank you to Dr. Meyer, Tamara, and Maggie for that informative presentation and thoughtful Q&A. I want to remind everyone that the recording of this webinar will be available on the registry website, and we ask that you take a few moments to answer our brief survey, which you'll see just as we end. So thanks again for joining us, and everyone have a wonderful day.